Hello friends. Today we are going to discuss about Neuroleptic Malignant syndrome. I am Dr. Suresh Vadadmat, Professor of Psychiatry working at NMS, Bangalore. In this video, I am going to discuss about Neuroleptic Malignant syndrome, how to diagnose it, what is the etiology, what are the differential diagnosis, management, and legal perspective of Neuroleptic Malignant syndrome. This Neuroleptic Malignant syndrome was first observed after the introduction of haloperidol. It was noticed in 1960 by a group of French scientists. They called it as Syndrome Melin des Neurolepticus, which was translated into English as Neuroleptic Malignant syndrome. This Neuroleptic Malignant syndrome can be defined as a rare but a life-threatening disorder, which is idiosyncratic, very difficult to guess, and it can be considered as a dose-dependent neuropsychiatric emergency associated with the exposure to dopamine antagonist, commonly the antipsychotic drugs, and also withdrawal of dopamine agonist can induce neuroleptic malignant syndrome. Let's understand the neuroleptic malignant syndrome from the background of dopamine pathways. As you know, there are four important dopamine pathways. One is mesolimbic pathway. Here, the dopamine nerves are projected from ventral tegmental area towards the limbic system. Second one is mesocortical pathway. Again, here the fibers from ventral tegmental area are projected across the cortex. Third one is nigrostriatal pathway. Here, the projections are from substantia nigra towards putamen, thalamus, and dorsal striatum. And the final one is tuberoinfundibular pathway. Here, the dopamine nerves are projected from hypothalamus towards the pituitary gland. Let's understand how these dopamine pathway play an important role in neuroleptic malignant syndrome. As you see, the first and the foremost is mesocortical, which is very important in the development of negative symptoms when there is increased dopamine. The second one is mesolimbic. Here, the positive symptoms can be seen when the dopamine is increased. That is the mesolimbic. Moving to the third, nigrostriatal pathway. Here, from the substantia nigra, you can see the projections are towards the striatum. And the final one is tuberoinfundibular. Here, from the hypothalamus towards the pituitary gland. As you see here very clearly, the nigrostriatal pathway, whenever a high potency antipsychotics are given, and that leads to rigidity. So, this pathway is considered to be involved in rigidity of neuromalignant syndrome. The second one is the tuberoinfundibular. Here, the projection from hypothalamus to the pituitary gland. Any amount of blockade by high potency medications can cause hyperpyrexia. The third one is, the important is mesocortical. Here, the projections are from ventral tegmental area across the cortex, especially the prefrontal cortex. Hence, altered mental status can be seen. So this is the basic, simple hypothesis which can be understood how the neuroleptic malignant syndrome is produced. Now let's understand the neuroleptic malignant syndrome. The typical clinical feature should occur only after the exposure of antipsychotics. Either the rapid increase in the medication or a potent injectables such as haloperidol or fluphenazine, risperidone injections can precipitate neuroleptic malignant syndrome. But however, you need to understand it is an idiosyncratic reaction, sometimes dose dependent and very difficult to predict. What are the important four symptoms? Altered sensorium or altered consciousness, muscular rigidity, which is like a lead pipe rigidity you can see, further fever and autonomic instability. These four important symptoms will lead to the definition of neuroleptic malignant syndrome. I'll repeat: altered sensorium, lead pipe muscular rigidity, fever, and autonomic instability. And further, if you do the blood investigation, there will be increased CK levels, creatinine kinase, will be increased and it should be more than 1000 international units per liter. Further, increased SGPT, SGOT, and LDH enzymes. Further, if you look at the electrolytes, hypocalcemia, hypomagnesemia, and hyperkalemia, hypophosphatemia, hyperuricemia, and acidosis is common. And also, leukocytosis and thrombocytosis is well known in neuroleptic malignant syndrome. Further, proteinuria and myoglobinuria is the hallmark. And this results because of the rhabdomyolysis which occurs because of the lead pipe rigidity. This rhabdomyolysis will cause myoglobinuria and proteinuria, which causes the renal failure. This acute renal failure in neuroleptic malignant syndrome means it is a poor indicator of outcome. That means there is a high chance of mortality. Now let's understand which are the neuroleptic malignant syndrome causing agents. First and the foremost is antipsychotics. Name the antipsychotics, either the first generation or the second generation. All of them are known to cause neuroleptic malignant syndrome. They are aripiprazole, chlorpromazine, clozapine, fluphenazine, haloperidol, olanzapine, risperidone. So, all antipsychotics are known to cause. The second one is antiemetic drugs. Domperidone, droperidol, metoclopramide, promethazine, prochlorperazine are known to cause neuroleptic malignant syndrome. Along with this, sudden withdrawal of anti-Parkinsonian drugs can also trigger neuroleptic malignant syndrome. So, these are the drugs which are known to cause neuroleptic malignant syndrome. But however, how to diagnose it? There was no uniform diagnosis available. Hence, in 2011, an international multi-speciality consensus group drafted a NMS diagnostic criteria, which is called as Delphi method. Let's look into this Delphi method. The Delphi method has 100 score. This score is based upon the importance and severity of the symptom. The first one is the exposure to dopamine antagonistic or sudden withdrawal of dopamine agonist within the past 72 hours. If it is there, the score of 20 should be given. Hyperthermia, that is, if the patient has more than 100 degree Fahrenheit and at least on 2 occasions measured orally, then the score of 18 to be given. If there is lead pipe rigidity, you need to give 17 score. Mental status alteration, that means altered sensorium. If it is reduced or fluctuating level, you need to give score of 13. Elevated creatinine kinase, at least 4 times the upper limit of the lab, then the score of 10 should be given. Further, the sixth important is sympathetic nervous system liability, that means autonomic instability. Either it will be seen as BP elevation, that is systolic or diastolic more than 25% above the baseline. Blood pressure fluctuation more than or equal to 20 millimeter of Hg diastolic or more than equal to 25 millimeter of Hg for systolic within 24 hours. Sweating, that is diaphoresis, and urinary incontinence. At least 2 of these 4 should be there. Further, hypermetabolism, which is depicted as increased heart rate, increased respiratory rate, and negative workup for infection, toxic, metabolic, or neurologic causes. That means you have ruled out either meningitis, encephalitis, or any metabolic encephalopathy. If you have ruled out, then you need to consider neuroleptic malignant syndrome depending upon the score. But however, let me be clear, till date, there is no definitive diagnostic lab test is available. NMS does not have any universal accepted diagnostic criteria or specific lab diagnosis. By doing CT scan or MRI or any blood test can be diagnosed NMS? No. It is simply impossible. Here, neuroleptic malignant syndrome is a cluster of symptoms which arise after the exposure of antipsychotics. Hence, this diagnosis is based upon history, symptoms, and observing the signs. So, neuroleptic malignant syndrome is a diagnosis of exclusion, as the differential diagnosis of the symptom complex is very broad. That means neuroleptic malignant syndrome, whatever the symptoms are there, it can be seen in other many conditions. We will be discussing that shortly. Now let's understand what are the risk factors for neuroleptic malignant syndrome. The first and the foremost is pharmacological treatment. How the medicine was started, what is the potency of the medication, like high potency haloperidol deconate, parenteral administration, that means giving IV or IM, polypharmacy, and also rapid increase in the medication can cause, it is not must, can cause environmental factors like physical restraint, dehydration, high temperature, age, elderly age, multi comorbidities. If the person has anemia, malnourishment can also play a role. Genetic liability. That means we do not have at this point of time what are the genetic liability which can predict neuroleptic malignant syndrome in a given patient. But however, if a person had NMS in the past, you need to be very careful. That means there is a genetic vulnerability and he can have NMS anytime. Further, the other risk factors are presence of mood disorder like especially mania or depression along with psychosis. High potency drug, rapid increase in dosage, first generation antipsychotics is generally considered intellectual disability. Further, organic brain insult is there, reduced serum iron level. That is one of the important indicators which has been found to occur in neuroleptic malignant syndrome and geriatric age. So these are the commonest risk factors which have been observed across the studies, but however, they are not definitive in nature. You can say, yes, these are the risk factors that's there. That means this person has high risk to develop neuromalignant syndrome, but we do not have any blood test or imaging study to say this person is going to develop neuroleptic malignant syndrome or he has already developed, which can be positively be identified by any lab diagnosis. Then what is the need for to know about neuroleptic malignant syndrome? That is, what is the seriousness of NMS? Here you need to understand the incidence of NMS is slowly decreasing because of probably the physicians have become very aware of neuroleptic malignant syndrome, or else we are switching from first generation to second generation antipsychotics. That may be the possibility. And the incidence in the first generation antipsychotics, it was somewhere around 1 to 0.9%. But nowadays, it has decreased dramatically. It is around 0.07% incidence of neuroleptic malignant syndrome for the people who have been exposed with antipsychotics. But you need to understand, it is difficult to predict. It is an idiosyncratic reaction for antipsychotics. And it can develop immediately, or else it can develop after many years of receiving antipsychotic medication. So, no psychiatrist can diagnose or predict, yes, this person is going to develop neuroleptic malignant syndrome. You can predict the neuroleptic malignant syndrome only by examination, good history taking, and seeing the signs and symptoms of NMS when you have admitted the patient in your ward. What is the outcome? The symptoms of neuroleptic malignant syndrome will resolve in 2 to 3 weeks. That means you need to keep the patient for a period of at least 2 weeks. And you need to stop the offending drug immediately. That means if you have suspected an antipsychotic which is triggering neuroleptic malignant syndrome, you need to stop that. Please understand. Some of the studies says there is 30% mortality if a person has developed neuroleptic malignant syndrome. But however, because of the good ICU care, availability of electrolytes, and also rapid correction which we do in the hospital, the mortality has now decreased 15 to 20%. But if you look at the old literature, it is 30%. Now it has come down to 20%. But however, we need to be very careful. 20% mortality is very high. Let's look into the etiology of neuroleptic malignant syndrome. Why it occurs? What is the basis? This NMS. First and the foremost, the pathophysiology is not known. Whatever we are discussing is the hypothesis which has been put forward. First and the foremost is dopamine receptor blockade. Once the dopamine for the nigrostriatal pathway and hypothalamic circuit are blocked, this lowers the concentration of dopamine metabolite, that is homovanillic acid in CSF. This can induce neuroleptic malignant syndrome. Further, the toxicity effect of antipsychotic compound on musculoskeletal fibers. That means the certain patients are vulnerable for antipsychotics. These antipsychotics can cause toxicity to the muscle fibers, and this can cause rhabdomyolysis and then myoglobinuria and renal shutdown. Further, certain patients are vulnerable, that is genetic linkage. Further, D2 gene polymorphism has been blamed. Further, alteration in GABA is also being considered. Enhanced serotonin secretion can also cause neuroleptic malignant syndrome, and reduced acetylcholine has also been considered for one of the factors for development of neuroleptic malignant syndrome. However, the recent studies talks about pro-inflammatory cytokines such as interleukin 1, alpha and interleukin 6 and tumor necrosis factors. These factors activate the enzyme kynurenine enzymes that catalyzes the production of 3-hydroxykynurenine. This 3-hydroxykynurenine is considered to be neurotoxic. And this neurotoxic initiates quinolinic acid instead of neuroprotective kynurenine acid. So please understand, this 3-hydroxykynurenine is a neurotoxin. This neurotoxin quinolinic acid and decreased kynureninic acid will precipitate neuroleptic malignant syndrome. This is the recent hypothesis. Let's understand the development of symptoms. As you see, there is a dopamine antagonist has been given, that is antipsychotic. And once, if there is a blockade in thalamus, that is hypothalamus, this will lead to hyperthermia. That means temperature regulation is gone for a toss. Further, if there is a nigrostriatal blockade is there, further it will lead to sympathetic nervous system, which further causes granulocytosis, and blockade of nigrostriatal causes extrapyramidal symptom, muscle rigidity, and increased muscle metabolism. And if you go to the blockade in the frontal lobe dysfunction, that is mesocortical, which leads to altered mental status. So you can understand how the 4 important symptoms which arises because of neuroleptic malignant syndrome, that is lead pipe rigidity, altered sensorium, leukocytosis, and further you can see hyperpyrexia, that is hyperthermia, and also autonomic instability can be explained by this simple pathway. Let's understand what are the differential diagnoses for neuroleptic malignant syndrome. There are various causes which have been discussed, but one of the commonest factor for differential diagnosis is many a time patients require 2 or more medications. That is polypharmacy, where we need to give an antipsychotic. At the same time, a patient may also require an antidepressant or a mood stabilizer. And all these medications can cause side effects. And those side effects can also mimic neuroleptic malignant syndrome. Let's look at each one of them. First and the foremost is infection. You need to rule out the infection. Encephalitis, meningitis, further post-infectious encephalomyelitis, brain abscess, sepsis, and also the recently which have been discussed is NMDA encephalitis. So these are also been known to cause or mimic neuroleptic malignant syndrome. Further, psychiatric and neurological symptoms like catatonia, agitated delirium, extrapyramidal symptoms, seizures, structural lesions in the midbrain also can present like neuroleptic malignant syndrome. Further, toxic pharmacological agents, salicylate poisoning, malignant hyperthermia because of inhalation of the anesthetic agents like succinylcholine and others, serotonin syndromes, which I'll be discussing in a new video, that is monoamino oxidase inhibitors, migraine medications, triptans, and also substance of abuse like amphetamine and methamphetamine, cocaine. Withdrawal of certain drugs can also mimic neuroleptic malignant syndrome. Endocrine disorders like thyrotoxicosis, pheochromocytoma, carcinoid syndrome, paraneoplastic syndrome can also mimic neuroleptic malignant syndrome. Finally, the heat stroke. So these are the various differential diagnoses you need to understand, and they will mimic like neuroleptic malignant syndrome. And so when you treat neuroleptic malignant syndrome, you need to rule out all these causes, because neuroleptic malignant syndrome is a diagnosis by exclusion. Further, how to differentiate between neuroleptic malignant syndrome and serotonin syndrome. In serotonin syndrome, it is caused by the administration of SRI, that is serotonin reuptake inhibitors. Here, CPK levels will be normal, no leukocytosis, no rigidity. But however, the hallmark of serotonin syndrome will be hyperreflexia, myoclonus, seizures, ataxia, diarrhea, and vomiting. That means there will be hot flushes with the patients, and those patients will have this hyperreflexia. Further, how to differentiate neuroleptic malignant syndrome from malignant hyperthermia? Here, in malignant hyperthermia, if a patient is exposed to hallucinated anesthetic agents, within hours, the patient will develop malignant hyperthermia. Further, central nervous system infection. For them, you have to do CSF analysis and radioimaging, like encephalitis and meningitis. Further, lithium toxicity also will come as NMS. For that, you need to differentiate. There is no rigidity, no hyperthermia, no leukocytosis. CPK levels will be normal. But however, the patient may have hyperreflexia, seizures, serum lithium's level will be very high. Further, catatonia. Sometimes catatonia and neuroleptic malignant syndrome is very difficult to differentiate. But however, in catatonia, there will be symptoms of psychosis or depression prior to the onset of this kind of rigidity. Echolalia, echopraxia, mid-Gehen, mid-Machen, grasp reflex, automatic obedience, such symptoms will also be noted in catatonia. But however, in NMS, it will be absent. Further, you need to understand, a patient with neuroleptic malignant syndrome can also have serotonin syndrome or catatonia. That means combination of two syndromes can also be there in a single patient. You can't say just the patient has only NMS or only serotonin syndrome. There are literature to say that patient with neuroleptic malignant syndrome also had serotonin syndrome. So you have to be very careful, and you need to investigate and also examine the patient thoroughly. Now let's move into the management of neuroleptic malignant syndrome. The neuroleptic malignant syndrome can be divided into three important severity. First one is mild NMS, moderate NMS, and severity of NMS. What is mild NMS? In mild NMS, there will be mild rigidity, mild catatonia, and or confusion will be there, with the temperature will be less than 100.4. Heartbeat will be less than 100. So here you can manage by stopping the offending drug and starting benzodiazepine medication. In moderate neuroleptic malignant syndrome, here there will be moderate rigidity, there will be worsening of catatonia or rigidity, confusion will be there, temperature will be less than 104 degree Fahrenheit, heart rate between 100 to 120 beats per minute. And this is moderate NMS. You need to consider giving bromocriptine or amantadine. And the final one, severe neuroleptic malignant syndrome. There will be severe rigidity and severe catatonia, severe confusion, temperature more than 104 degree of Fahrenheit, heart rate more than 120. Here you need to consider giving tentrolin plus. But however, in all these mild, moderate, and severe, you need to do aggressively supportive management. Hence, you need to admit the patient in ICU. So how the management starts? First and the foremost, stop the offending drug. Or if you're suspecting an antipsychotic, to induce this, stop the offending drug immediately. ICU admission, do investigation for blood, biochemistry, for LFT, that is liver function test, renal function test, hemogram, CT scan, CSF analysis. If required, MRI can also be done. Thyroid function test, investigation for fever, serial creatinine phosphokinase need to be done. Electrolytes for sodium, potassium, calcium, phosphorus, and magnesium to be done. At the same time, you need to give instruction for 6th hourly pulse, BP, respiratory rate, input and output chart need to be maintained. Supportive management should be very aggressive. Adequate hydration, and if required, nasogastric tube feeding should be done if the patient is unable to eat. Correct the electrolyte imbalance. Treat metabolic acidosis. You need to change the posture of the patient, because if the patient is having a rigidity, he may develop bed sores in a period of 1 to 2 weeks. And you may have to consider administration of low weight heparin to prevent pulmonary thromboembolism or disseminated intravascular coagulation. And how to decide to give antidote? Here, we need to consider depending upon the severity. First and the foremost, you need to understand there are 3 important management. As I mentioned earlier, in the mild cases, you will be giving benzodiazepine, such as lorazepam and diazepam. If you are giving lorazepam, 1 to 2 milligram IV or IM, which can be given 6th hourly, and monitor the patient. If you are giving diazepam, which is slightly long acting, you have to give 10 mg 8th hourly. This is only for mild neuroleptic malignant syndrome. If the patient has moderate severity of neuroleptic malignant syndrome, you need to give bromocriptine, that is 2.5 milligram 8th hourly. However, either you can consider bromocriptine or amantadine. If you are considering amantadine, you have to give in between 200 to 400 milligram daily in 3 divided dosages. And if the patient has severe neuroleptic malignant syndrome, you need to give dantrolene, that is in the dosage of 1 to 2.5 milligram per kg initially via intravenous infusion, followed by 1 milligram per kg infusion 6th hourly to be given, and you need to monitor the NMS. Invariably, NMS lasts for 2 to 3 weeks. And as I mentioned, bromocriptine is started with 2.5 to 8 milligram BID. That is, bromocriptine is a dopamine receptor agonist. You can also consider dantrolene if it is a severe NMS. It is administered intravenously in a dosage of 1 to 2.5 milligram per kg body weight. Here, dantrolene causes muscle relaxant by inhibiting the calcium release by the endoplasmic reticulum, and consequently decreases intracellular calcium availability and decreases the rigidity. If the patient fails either bromocriptine, dantrolene, then you can consider ECT as the last resort. Sometime, if the patient has severe rigidity, you have started dantrolene, you can also start ECT concurrently. What is the course and outcome of neuroleptic malignant syndrome? Here, the patient's symptoms start resolving after 7th day. Symptoms usually last for 2 to 3 weeks. By the end of 4th week, NMS usually disappears. Rechallenging of antipsychotics can be required in a chronic schizophrenia. In such a situation, start with the newer antipsychotic, maybe 2nd generation. Start with the low dosage and go slow. Talk to the patient and family member, and need for antipsychotic need to be discussed. And it needs to be weighed against the neuroleptic malignant syndrome recurrence. Recurrence is 30%. That means today, if we have treated 100 neuroleptic malignant syndrome patient, if you restart antipsychotic after 1 week down the line, then 30% of the patient there will be recurrence. And before you start, give a washout period of 2 weeks at least. Sometime if the symptoms are coming very fast, start electroconvulsive therapy, and later you can start antipsychotics. If the ECT is not available or the patient and the patient family member refuse to give consent with ECT, you may have to start antipsychotic within 1 week of resolution of symptom with neuroleptic malignant syndrome. What are the complications of neuroleptic malignant syndrome? The complication is aspirational pneumonia, because here the patient will have rigidity and he will be bedridden. Invariably, the muscle tone decreases, sometime inside the esophagus, and there will be regurgitation. So aspirational pneumonia is common. Acute renal failure, which is seen because of myoglobinuria. Disseminated intravascular coagulation, multi-organ failure, reversible dilated myocardiopathy also is known, and it is called as Takotsubo myocardiopathy. And this is because of autonomic instability which lasts for 2 to 3 weeks. Further, there will be cardiac arrhythmias which is seen because of electrolyte imbalance and also because involvement of blockage of D2 receptors by antipsychotics. Sometimes patient will go into coma and death. So these are the severe complications of neuroleptic malignant syndrome, and you need to understand 30% of them will have mortality. Let's understand what are the medical legal perspective of neuroleptic malignant syndrome. Should I educate the patient about NMS before starting an antipsychotics? No. You need not tell the patient regarding NMS when you are starting any antipsychotics, because it is an idiosyncratic reaction. And if you develop neuroleptic syndrome and there is 20 to 30% mortality, no person on this earth will take antipsychotics. And as you know, the occurrence is 0.07%. It is an idiosyncratic reaction and a very rare side effect of antipsychotic. I would rather not call it as a side effect. It is an idiosyncratic reaction to an antipsychotics. Now the question is, will court punish me if a patient under my care develops NMS? No. The simple reason is neuroleptic malignant syndrome is an idiosyncratic reaction to an antipsychotics, hence difficult to predict. It is difficult to predict by any good psychiatrist or experienced psychiatrist. But however, you need to suspect whenever the patient develops rigidity, hyperthermia, altered sensorium, leukocytosis, increased CPK level. Hence, the court will not punish you. The court will not consider you as a superhuman or a god, because neuroleptic malignant syndrome is very difficult to predict. Hence, you need not tell the patient or the family members with regard to NMS. To conclude, my dear friends, neuroleptic malignant syndrome is associated with all antipsychotics, both first generation and second generation antipsychotics. Whenever there is rigidity, fever, altered sensorium, please suspect NMS and stop the drug, especially the antipsychotic. Be aggressive in supportive treatment, admit the patient into ICU, 6th-hourly TPR BP monitoring, and also input-output chart. If required, start bromocriptine, and if the rigidity is very severe, start dantrolene. And remember, if the patient has developed NMS, talk to the family members, discuss about the mortality around 20 to 30%. One of the key important point you need to remember is suspect if there is rigidity, if there is fever, if there is altered sensorium, and if there is diaphoresis, sweating. Suspect, stop the medication, start the supportive treatment early, and then you can save the patient. Thank you very much for giving your valuable time. Stay safe.